So my name is Mitu Mehta. I'm an assistant clinical professor of ophthalmology. I'm a retina specialist here at the Gavin Herbert Eye Institute at UCI. Welcome. Welcome. And I'm going to talk to you guys today about an age-related retinal disease or eye disease called flashes and floaters. Dr. Riazi over here will be talking about macular degeneration. We ask that you hold your questions to the end of each section, and we'll go into that, and then together we can go over additional questions if you have them. So let's get over basic anatomy. This is what the eye looks like to you guys when you guys look at someone's eye. You see the eyelashes up here and down here. You see the sclera, which is the white part of the eye. It's covered in a wrapping called the conjunctiva. There's a clear dome over the front of the eye called the cornea. You can see the reflection of it right there from the camera. You see this blue iris, and you see this black hole, which is the pupil. I won't be talking about any of that because I don't deal with any of that stuff. I talk about the back of the eye. So if you look at the eye, like this eyeball is looking this way, this is the cornea here, this is the iris, this is the lens that becomes a cataract as you age, and other people will be talking about that as well. I cause those more than I fix those because I do surgery back here. This space, this big white space, is called the vitreous. So I'm a vitreoretinal surgeon. And the reason we do vitreoretinal surgery is the retina is this lining in the back wall of the eye. And this goes in a big nerve that goes into the brain. So technically the retina is part of the brain. So I'm the most specialized type of brain surgeon you can find. The center of the retina is this little divot right here. It's called the fovea, which is in a central area called the macula. Macular degeneration affects that area. The vitreous here is this jello type material. It's made out of literally the same thing jello is made out of, collagen. And as we're young, it becomes it's very solid. When you're born, it's really what inflates the eye, what the eye grows around to make the eye a round ball. But as we get older, like into our 20s and 30s, most of you guys haven't reached there yet, right? This starts to break down. And as it breaks down, the things that are inside this collagen matrix, they start to move. And we start to see them as floaters. This is what the retina looks like when I look at the back of the eye. This whole area here is called the macula. The center here is called the fovea. The circle is around the optic nerve. These red things are blood vessels. The thick ones are veins. The thin ones are arterioles. And that's what supplies the blood flow to the retina, which is this reddish looking thing here that's kind of lining everything like wallpaper. One thing we do when you come to see basically any retina specialist nowadays is you do an OCT scan. This is a scan that uses a laser much like an ultrasound uses sound waves. And with this laser, this OCT scan, you can look at the retina in cross-section. You see this green line here? That's the retina being scanned in this direction. And this picture here is if you take my fingers and turn them sideways, that's what we're looking at. We're looking at across the depth, because the retina is actually transparent to the eye, and you see reflections of the different layers of the retina with the scan. So it's like you're doing a pathologic specimen in a live person, which is nice because you can get these scans on every patient. It's relatively quick, painless, and it's got no known side effects. So I personally had my scans done hundreds of times to show my residents and my fellows and my trainees how it works, and there's no downside to that really. It's just a very bright light, that's all. So you see this little dip here. Again, this is the fovea. This is a normal looking OCT scan. So if I take a picture of the retina in this way, and I see a very wide angle view, you see something a little bit different here. You see this little circle right here where the square is. This is what many of you have probably noticed kind of floating around your eye. Sometimes it's a circle, sometimes it's a squiggly line, sometimes it's a weird shape, it twists and turns, and it kind of floats around. You might notice it more if you're looking at a white wall or a bright sunny sky or a blue sky. This is a floater. We call this a PVD, or a posterior vitreous detachment. This is when the back wall of the eye has the vitreous separate from it. The reason you see a circle here is this is the area where the vitreous was attached to the optic nerve. So it was not transparent. It actually has some thickness to it. And so when it separates from that, you see that ring from where it was attached. You see it floating around. That ring is called a Weiss ring. Before the vitreous separates, you get a kind of zoomed up view of the Weiss ring here, this big floater. This is a normal thing. This happens to everybody at some point in their life. So if this happens to you, you see one big floater, don't worry about it. You're normal, okay? Before this happens, you get something called vitreomacular adhesion, because when you're young, your vitreous is still attached to your macula as well as the optic nerve. So you see the layer of the vitreous here attached to the fovea as well as attached to the optic nerve right here. This is where the nerve goes into the brain. And you can see the vitreous attached here. If the vitreous starts to pull on the retina, this can cause vitreomacular traction. That last eye, this one here, is 20/20. This patient here is 20/50 because the vitreous is pulled so hard it's actually separated the layers of the retina and is pulling on the fovea. This is something we can fix surgically in the office, or sometimes we just wait and it releases on its own, depending on kind of what it looks like and how symptomatic it is. This patient I did surgery on because they were 20/50, and when I removed all the vitreous and relieved this traction, they went back to 20/20 vision. So you can see the vitreous pulling on the fovea here. If the vitreous pulls too hard, it can rip a hole in the retina. So this patient has a retinal detachment. You can see a tear in the retina over here, this big rip. And as a result, this vitreous jelly, which is now broken down and has become relatively liquidy, is going through this large hole and peeling the wallpaper off the back of the wall. Before this happened, that's the time when you want to see me, okay? Before this happens. Obviously, after this happens, I'll fix this as well, but I'd rather fix this before it becomes a detachment. And that's when you get flashes. So flashes happen when the vitreous starts pulling on the retina, because the only thing the retina can sense is light. And so it's sensed as a flash of light. You see the flashes as the vitreous starts to separate. When it separates from the optic nerve, it can cause some problems, but most people don't notice that kind of flashing. It's very dim. But when it pulls on the retina, you may see a very bright flash. You might notice it more at nighttime, when you close your eyes, or if you're driving late at night, or you're in a dark room, because it's actually relatively dim compared to the bright world. But when you're in a dark room, it seems like a very bright flash. Oftentimes it's off to the sides because those areas pull off later than the stuff in the back. So oftentimes after you get the PVD, or the posterior vitreous detachment, the peripheral vitreous gets pulled on as it's separating from the wall of the eye. And you get these flashing lights. If you get repeated flashing lights in one area, and it rips a hole in the area, you may get a shower of floaters. Hundreds, maybe thousands of floaters floating around. Not just that one big one we saw, but a whole bunch of them that don't go away. Oftentimes it's in a cloud kind of configuration. And if you come in after that, that's before the retina detaches. I can put a laser in this area and I can spot weld it down with this laser in the office. It takes, about 10 to 15 minutes to do this procedure, but you're awake, we do it in the office the day you come in. We do it right away. It's something that's relatively easy to do. It's very bright light. Some people have a little bit of trouble doing it, but I've never not been able to do it in somebody. And if you can do that, you can completely prevent this detachment from happening almost all the time. So that's the ideal place to go when you start seeing repeated flashing lights and a shower of floaters. When it gets to this place, you're starting to see a curtain coming and blocking part of your peripheral vision. When you see it up here, you would actually see this curtain down below, because everything that you see inside the eye is actually inverted by your brain. So things that are in the superior retina will be appearing down below, and things that are in the inferior retina would appear from the top, okay? Same with left and right sides, the opposite. So this is the detachment and this is the tear. So again, the symptoms of the detachment, you'll get the flashing lights while the vitreous is pulling on the retina. You'll get a shower of floaters when it actually rips, and you get the dark curtain blocking the vision. So these are the three symptoms I want everybody to remember. If these things happen, I need you guys to call 1-800-UCI-2020 or 949-UCI-2020 and get a hold of the operator and tell them, I'm suddenly seeing these things, I need to see an ophthalmologist, ideally a retina specialist, okay? There are 5 of us here in the retina division, as well as our 2 fellows. So there are 7 of us who can see you 24 hours a day, 365 days a year. And this year, 366 days, okay? We don't take leap year off. We don't take time off for coronavirus. We just wash our hands and use hand sanitizer like you're supposed to use. And I've been giving people fist bumps instead of shaking hands recently, so you may notice that right now. But during flu season in general, just take care of yourself, clean your hands. When you wash your hands for 20 seconds which is 2 times singing happy birthday with the soap being all soapy but not rinsing it off yet, okay? Just a reminder, sorry, public service announcement. I'm getting a little, everyone's kind of going a little crazy. UCI banned all travel, so I can no longer go to any of my meetings for the time being, for this meetings. My alma mater, MIT, just closed all the classes. Stanford's moved everything to online courses. And they're forgetting the fact that this is a disease that doesn't affect young people, it affects you guys. So you guys need to take a little more care, okay, and take this seriously. Other people are taking it too seriously. I feel like the elder generation is not taking it seriously enough. So somewhere in the middle we need to meet on this kind of thing. So that's flashes and floaters. This is the retina team. Myself, Dr. Brown, Dr. Riazi, Dr. Liu, and Dr. Koopman, our chairman, are all available to help you. And we have research that we do here at the Gavin Herbert Eye Institute, and it's greatly helped by the help of grateful patients like you guys yourself. So if you want to get a hold of anyone here, you can contact Janice Briggs if you would like to support our research as well. Does anyone have any questions? How many years ago? Because in 1940, it was. Because in 1940, the first retinal detachment surgery was done.
It was early, like in the 50s.
Yeah, the 50s, it was kind of tough. You pretty much had to be in Boston to get a detachment fixed, Boston and New York. But now it's much more fixable. I was in the operating room until midnight on Friday night fixing them. I do them all the time. I have some tomorrow. That's what I do. So as the vitreous separates, that's a normal aging process. We don't want that to stop. We want that to finish. Because once the vitreous separates entirely, you're kind of home free a little bit, barring major trauma. Once it's in progress, you need to take it easy until it does separate. You don't want to do anything too vigorous, too aggressive. My guess is that most of you guys are not MMA fighters or boxers. So, you want to avoid head trauma, obviously. But really vigorous activity can shake it some more, and that can cause a violent ripping of the vitreous, which can cause the retina to tear. So there's lots of studies about this in general. Basically, it's collagen breakdown. It's the reason people's skin wrinkles. It's the reason why a baby's tush is so firm and mine's not so much, right? And all of these technologies come down to the fact that over time, oxidative damage, inflammation, these things break down all parts of your body, including the vitreous jelly. And so in terms of reducing those things that we can do, and people have done this, and people are doing this naturally, part of the reason why people don't have the problems they used to have back. So when I was a young person, it was very common for people to get major cataracts in their 50s and 60s. And we still see that in the third world. And the reason we don't see that as much here, people tend to get cataract surgery later here, in their 70s and 80s, even though they get it with better vision than they used to, is because they wear sunglasses. Because the sun is the greatest force of inflammation that you're going to see. It's a million times brighter than my lights in my room here, and that is a great source of inflammation that breaks down basically everything. So sunglasses. I particularly like brown polarized sunglasses because brown also blocks the visible spectrum in the blue spectrum of light as well as ultraviolet. So the blue high energy light can also cause damage to the eye and the retina as well. Let me show you a picture of it. So if you look very carefully at this picture on this, what was supposed to be a normal eye, but it's not really a normal eye. If you look very carefully, you can see wrinkles here in the retina, almost lines, okay? That's called an epiretinal membrane. Epiretinal membranes, for the most part, happen just because of age and time. But if you have an inflammatory disease, they can happen more. And these things are on the surface of the retina, scar tissue grows and it can contract. Unless it bothers the center of the vision and causes distortion, we usually just watch them. They do happen to many, many people and never need to be treated. But I do repair them relatively frequently. I have 2 tomorrow that on Thursday that I'm fixing because it does distort vision in some people. Not necessarily an OCT scan. You need an exam for sure because you want to look at the peripheral retina. The OCT looks at the back of the eye, but we get them every time we see a patient in the retina clinic because the scans can see things that a human eye just can't see. So we just get them as part of the course of seeing everybody in the retina clinic. But if you get the flashes and floaters, you should get an exam because the flashes precede the detachment and the tear. And if we can catch you early in the tear stage, we can fix it and never have a detachment, which we want to avoid at all costs. So there's different answers to that question depending on kind of what the eye looks like and what part of the retina is detached. When the macula is still on, you really want to fix that as soon as you can because you want to maintain the central vision. So while your central vision is still good, that's fundamentally the most important. So you really want to kind of rush to get that done. There's studies that say people needed to get that done within 24 to 72 hours. That's the kind of, that's kind of an emergency. You really kind of get that going. Once the macula is off, there's good data to show that anywhere between 7 to 9 days, you don't lose any more ground than otherwise. But after that, then you start to develop other possible side effects like scar tissue forming and causing tractional membranes. We call that PVR, and that can lead to major problems as well. So we do want to fix that as soon as we can. I have fixed detachments that have been there for years, and people did get some vision back. They most certainly weren't 20 anything. They were probably counting fingers, but they were able to have formed vision and see the front door, which is fundamentally important to be able to walk around and that sort of thing. Yes. Usually not in that eye, but the other eye. Because if you get the one eye fixed, the other eye is just as likely to get a tear as the first eye was. And if it doesn't get fixed and it causes a tear again, a detachment is also possible and more likely. All right, with this, I'll invite Dr. Riazi to come up to talk about macular degeneration.